Good morning. My name is Nomuzi Xaba. I've been living with lupus for most of my life, actually, but I didn't know that I had lupus. I was diagnosed with lupus in June 2017.
My name is Ntandokazi Letele. I've been diagnosed with lupus since December 2019 on the 5th.
My name is Nuri Budram. I am 64, turning 65 next month. And I've been diagnosed with lupus at the age of 24.
I have got 4 years of living with systematic lupus erythemas, where I was diagnosed in May 2017 in Albert Luthuli Central Hospital.
What is rheumatoid arthritis and SLE? Who gets rheumatoid arthritis and SLE? And what are the first signs that you actually have these conditions? And is there a cure? I'm your host, Dr. Musamtomene, and signing with us today is Trifosa Ntswelengwe. On Vital Signs, we focus on autoimmune disorders today, specifically rheumatoid arthritis and lupus, also known as systemic lupus erythematosus. Coming up on the program, we will listen to inserts produced by Wandile Mofokeng, who spoke to two women, one that suffers from rheumatoid arthritis and the other lupus, as they share the challenges that they have and the challenges that they face on a daily basis with these autoimmune disorders. We'll then speak to Professor Emeritus at the Division of Rheumatology there at the University of the Witwatersrand about rheumatoid arthritis and lupus. And then Dr. Marla McKay will answer your questions about COVID-19 symptoms. Remember that you can be part of the show by asking our guests some of the questions that you have on your mind, or you can simply share your view with us on what we're discussing. The number to call is 011-714-5861 or 011-714-5877, and you can share your thoughts with us on social media as well. On Twitter, it is at SABC Vital Signs, or Facebook, SABC Vital Signs. Vital Signs continues right after the ad break. Welcome back. This is Vital Signs. I'm Dr. Musamtomene. It is important to be explicit about the conditions that you may have with your friends and loved ones, because they may not be able to see what you're actually going through. By explaining your condition and the needs that you may have, they're better able to help you out as well as support you. And that is how author and teacher Marcel Baptista manages to live her life with the autoimmune disease called rheumatoid arthritis. She shared her story with us. Let's take a listen.
Author and teacher Marcel Baptista from Johannesburg has been living with an autoimmune disease called rheumatoid arthritis. We visited her to find out when was she diagnosed and how has she been affected by this condition.
My diagnosis was in 2010. I had been sick for a couple of months, not knowing really what was wrong. I was struggling to walk. I had breathlessness, painful joints. There were a lot of things going on, and chronic bronchitis, and so there were a mix of things.
For people living with RA, symptoms can differ. Marcel shared with us the kind of symptoms she was experiencing.
Movement is difficult, breathing is difficult because those muscles have to move and they're inflamed and enlarged. So there's headaches, there's your legs, hips, every single little bit of movement is very painful.
For someone living with a debilitating health condition, it is no doubt that it will impact your day-to-day living, and Marcel had to stop doing things she was used to doing.
So one of the things that I've had to stop is any impact sport or impact exercise. So I wasn't ever really a big sport fan, but running, the high impact things you can't do. And I try and do a little bit of everything, but the secret is to pace yourself. So you only do a little bit and stop, because overexerting any of your joints or your muscles just aggravates the inflammation and the pain that's already sitting there.
What could have been the contributing factor for Marcel to get RA? Could it have been genetics or environmental?
It was probably a little bit of both. So my mom had rheumatoid arthritis and fibromyalgia, but shortly after my diagnosis, my parents had passed away just before that, both of them suddenly, and I think that might have been the culminating factor.
Treatment for RA can be different and difficult to take because of how complicated the condition is.
You get supplements, vitamins, pain medication. One of the big ones is an immunosuppressant to decrease the immune system so that the activity of the disease actually rests rather than activates even more. Because it's so active, you need to decrease the activity in order for your body to manage a little bit better.
People may know of these autoimmune diseases, but according to Marcel, there isn't enough information to educate people about these conditions. Thus, she wrote a book to raise awareness.
I've got so involved in writing this story and my journey and insights and my ideas and what I do to try and feel better. And I thought I could then share this story with many other people that have the same struggles, that may not have a voice to say, this is what I'm feeling and this is what's going on. And it's also a tribute to the people in our lives who suffer alongside me, my sisters, my husband, my family. They also feel it takes a toll on them. So I wanted them included in the story, also for them to understand what's going on with me. So it's really an insightful book, all about the two diseases, or a few autoimmune diseases, and the best way forward to manage your lifestyle.
After the break, we speak to Professor Mohammed Tikle, a rheumatologist, about rheumatoid arthritis. Stay with us. Welcome back. This is Vital Signs. I'm Dr. Musam Tomeno. In this segment, we'll be focusing on learning about the most common of autoimmune diseases that we actually find in the world. We're joined by Professor Mohammed Tikle, a rheumatologist at the Chris Hani Baragwanath Academic Hospital. And let's start off our morning by saying good morning. Good morning, Prof.
Good morning, Dr. Intrabeni, and to the viewers. Thanks for having me on the show.
Great. It's really great having you here today because we're going to speak about autoimmune diseases. And I think it's an important one to cover, looking at our population and how, our health-seeking behavior and things such as that aren't necessarily the best in the world. So let's start off by talking about autoimmune diseases. What is an autoimmune disease, Prof?
Yeah. Well, I think let's start off by dissecting the term, right? Autoimmune. So we've learned much about immunology or immunity with the COVID pandemic. So the immune system normally functions as a guard against bacteria, viruses in the environment, right? What happens in autoimmunity, auto means self, the immune system unfortunately directs its artillery to the self, to the body. So it affects various parts of the body. In terms of rheumatoid arthritis, the primary target of the immune system then are the joints, okay? In other conditions, like multiple sclerosis, it would be the brain. There are what we call organ-specific autoimmune diseases, such as the thyroid disease, type 1 diabetes, pernicious anemia. So in general terms, we talk of systemic autoimmune diseases, and typical examples are rheumatoid, systemic lupus erythematosus, multiple sclerosis, and then the organ-specific ones, which include the thyroid disease, the pernicious anemia, and some others.
So how common are these autoimmune diseases in our population and our communities? Are there a lot of people that have some sort of shape or form of an autoimmune disease?
Well, I think fortunately it's not that common, right, to have autoimmune disease in the general population. But when it does affect an individual, it can have devastating effects if it's not recognized early and treated early. So, for instance, I can't give you, I can't give you a figure for autoimmune diseases in general, but if you were to take rheumatoid arthritis, at least in South Africa, the prevalence in the adult population is probably in the region of 0.5 to 1%. So 1 in 100, up to 1 in 100 individuals, especially in the urban areas, would be suffering from some form of rheumatoid arthritis. I think what's also important to recognize is that not everybody has the severe end of the disease, so
Okay.
to speak. So it varies in severity, and I think one size does not fit all, even if you have the same diagnosis.
A lot of the time, I think older patients would complain of having arthritis. And I mean, there are different types of arthritis that you would get. So is rheumatoid arthritis the same as the age-old, my knee is sore type of arthritis?
No. So rheumatoid is just one type of arthritis. Remember, there are more than 100 different types of arthritis. And most of the arthritis that occur are self-limiting disorders. Rheumatoid is a chronic, persistent form of inflammation of the joints. And just to bear in mind that, not every joint pain means you've got arthritis. It could be pain around the joint. It could be due to nerve compression. So joint pain is not equivalent to arthritis.
So with respect to the people that would get rheumatoid arthritis, what and who in the population should be aware of a certain number or certain symptoms and signs so that they go out and get the help that they need?
Okay, so rheumatoid arthritis can affect any age group, right? We see typically it peaking in the age group between, say, 40 and 55. Okay. And it's more common in women. The ratio is about 3 to 5 to 1. So for every 3 or 4 women who get rheumatoid, there'll be 1 male who gets rheumatoid. So the symptoms and signs, those are, not necessarily specific to rheumatoid, but the 3 things that we recognize as early features of rheumatoid. Firstly, stiffness of the joint. So if you have prolonged early morning stiffness of your joints, particularly your hand joints in the morning. Secondly, if you have swelling of the joints, and again, principally the joints in the hands, but also the knees or ankles. And the third thing is if you were to squeeze your forehand, and I'll try to do it here, the hand over the knuckles, if you squeeze and if you get pain, then that is also an indication of possible rheumatoid. So we talk of the 3 S's. Swelling, stiffness, and a positive squeeze sign as indicators of possible rheumatoid arthritis.
So how does a patient get diagnosed with something like rheumatoid arthritis? If you've noticed these signs, if you've spoken about them, and you go to a facility and they tell you, no, just go take some pain tablets and come back in a month's time if it's not getting any better. But how do we get a final diagnosis for patients?
So the diagnosis is based on a constellation of symptoms and signs. So it's unlike diabetes and hypertension, where, in hypertension, high blood pressure, we would just take a blood pressure reading and based on that, make a diagnosis. Or in diabetes, we look at the sugar. Here we'll have to look at the constellation of features. So as I mentioned to you that morning stiffness is one of the key symptoms. Swelling is important. So if you don't have a swollen joint, you do not have rheumatoid. And along with that is rheumatoid will always, at some point during the course of the disease, affect the hand joints.
Okay.
And then we look at certain blood parameters like the inflammation markers, the so-called CRP and ESR, and then the immunological tests. And they are the rheumatoid factor, and the newer one is the NTCCP test. But what I want to emphasize here is we do not start off by doing those tests, right? Both, especially the rheumatoid factor, it's positive in 80% of patients with rheumatoid. So you can have rheumatoid without having a rheumatoid factor positive. But the converse is equally true, that there are many other conditions other than rheumatoid arthritis where the rheumatoid factor is positive. And, we make this an issue when we teach our undergraduates and postgraduates that the diagnosis of rheumatoid is not based on blood investigations. It's based on a good clinical examination. And as I mentioned, swelling of the joints is one of the key features that we look for, along with the symptom of prolonged early morning stiffness.
Okay, before we get into treatments and sort of the management of people that would end up having RA and, look into lifestyles and things like that, we've got to call us Sibongile. Sibongile, good morning.
Good morning, sir.
Yes, so what is your question for Prof?
My question is that I've been diagnosed with rheumatoid since 1990. I'm 51 years old. And then now the problem that I'm having, I'm struggling to breathe these days. And then I'm coughing. And then I've done 2 tests of, the COVID, and then they've tested negative. Yes, and then I'm on the treatment since 1994.
Have you been following up for the treatment?
Yes, I am on chronic medication.
Okay. All right, Prof. So a lady who has been diagnosed with rheumatoid arthritis in the past, currently on treatment, complaining of having this residual and continual coughing and sort of chest symptoms. How do we go around trying to figure out what's wrong with the patient?
Well, I think the first thing to do is obviously a good examination by her doctor. She also needs to have a chest X-ray, because we do know that rheumatoid patients are more prone to a variety of chest-related problems, okay? So I think a chest X-ray is important. And beyond that, they might need to do further tests like a CAT scan of the lungs and so forth. We know that some patients with rheumatoid develop inflammation in the lungs, what we call interstitial lung disease. And of course, sometimes the medications we use to treat rheumatoid might also cause problems in the lungs. So I think the first is an examination, and of all the special investigations, I would say a chest X-ray is essential.
All right, thanks for that one, Prof. Smogile. I hope you got the answer that you're looking for. Very important, especially to all the people that do call in on the show wanting to get advice from the profs and the doctors and the people that we have on, is that the important thing is going out and actually seeing a physician, seeing a doctor who actually listen, who actually make sure that, they examine you and get a history and do the investigations that they need to do so that they can get to a diagnosis that assists you. Look, we continue the conversation with Prof. Tickley after the break. We'll talk about rheumatoid arthritis and SLE. Do you think that you might have these conditions? Do you know someone in your family that might have them, and you're looking to make their lives a lot easier? Well, stay tuned. We'll be back after this. Welcome back. This is Vital Signs. I am a lupus survivor and I intend to fight this illness with everything. These are the words from Praise Rendane Rasioboro, who is currently battling lupus nephritis. Praise was diagnosed with lupus in 2017 after struggling to get a proper diagnosis. She had to sit down with Wandile Mufokeng to tell us more about her experience with lupus. Take a listen.
Lupus can be a misdiagnosed health condition according to the Lupus Foundation of America. Praise Rasiorobo is one of many patients who was misdiagnosed and later found out that she has lupus.
So in 2017, I was diagnosed with lupus SLE, nephritis. I was 29 years old at the age, and it took quite some time for them to figure out what was wrong with me. So it was a few months of very uncomfortable pain and not knowing what was going on with me.
She describes her symptoms as life-changing because she was an active person before lupus.
I was highly fatigued. All I wanted to do was just sleep. I slept more than anything. I've never slept so much in my life. I would sleep at night and wake up the next morning and feel like I did not sleep enough. I was very tired. I could not eat because I had mouth sores, ulcers, and I was losing weight. It was abnormal. Like I just didn't look okay, and I had the rash. So they call it the butterfly rash.
Lupus is considered a systematic disease because it can affect just about every organ in your body, and treatment can vary. And for Praise, it has affected her lungs and she takes multiple medications for it.
I take medication for my kidneys on a daily basis just so they don't collapse, because a lot of lupus patients that have nephritis, which is for your kidneys, are on dialysis and they have kidney failure. So I'm fortunate enough not to have the kidney failure. I can still be maintained under the medication. And I take the anti-malaria, where it also boosts my immune system, vitamins and a lot of painkillers, because sometimes waking up, your body just hurts for no reason.
At some point, Praise had to do 6 trials of chemotherapy. It seemed to have worked for her, She unfortunately later had flare-ups and went into a coma.
It was during holidays, and then I tried to have time with my family, and a month later I fell back into a flare and I had to restart the chemo again, and it put me in a coma. So it was like kind of traumatic. I went into a coma and then I went totally disabled. I couldn't walk anymore. I couldn't talk, like everything was taught. And imagine teaching a 30-year-old at the time, things that I've always known to do my whole life, I had to kind of restart it.
Praise learned the hard way that she had to change her lifestyle to avoid getting flare-ups.
When the lupus came, you know, I had to kind of calm down, because I kind of know that there's certain things that trigger it, and just like an hour of fun or a weekend of fun would result in 2 weeks of me being in bed trying to just recover from what I did over the weekend.
According to Praise, there is enough information out there about lupus and people need to be aware of it. Thus, she also started her own foundation called Pretty Woman.
I think the best thing to do when you feel that you're not okay is to talk about it. On social media, there's so much you can find these days, you know. Just talk about it and you'll be surprised as to how many people can actually be referenced to people that can support you. And talking about it is a way of living. It's part of the lifestyle so that you don't fall back into that phase and get even more sick.
There are many types of autoimmune diseases, many of which have similar symptoms, which makes them very difficult to diagnose. It is possible to have more than one at the same time, with autoimmune diseases usually fluctuating between periods of remission, where you have little to no symptoms, and flare-ups, where you have a worsening of those symptoms. Autoimmune diseases often run in families, and 70% of those affected are women. Lupus is one of the most problematic of these autoimmune diseases that affects mostly women, and we found out more from lupus, or about lupus rather, from our special guest, Professor Mohammed. Prof, let's continue our discussion, and I think wrapping up the rheumatoid arthritis discussion around diagnosis and treatment.
Yeah, so I think it applies both for lupus and for rheumatoid arthritis. But early diagnosis is critical because in patients who've got early disease, intervention with our current medications makes a huge difference. So in rheumatoid arthritis, if we are able to make the diagnosis within, say, 6 months of the onset of symptoms, probably 80% of patients will go into remission just on the simple medications we have available in this country, like methotrexate. On the other hand, if the diagnosis is delayed, then in many patients, even the more expensive biologics, for instance, don't work that well. So it's critically important that patients recognize their symptoms that we discussed, as well as seek medical attention so that they can be referred to the appropriate specialty. Now, going on to lupus, of course, lupus and rheumatoid share one common feature, and that is the arthritis. So the arthritis that lupus patients get can be identical to the arthritis of rheumatoid, at least at a clinical level. But in rheumatoid, the main problem is the destruction of the joints, such that the patient becomes disabled and crippled and often requires surgery. In the case of lupus, the arthritis is usually a presenting problem, but it's much more easier to control. However, the lupus patient, we're more concerned about internal organ involvement, such as kidney involvement, as the previous patient spoke about, lupus nephritis. We're more concerned about involvement of the brain, the heart sometimes, the lungs. So we look for certain symptoms. So when a patient presents with joint symptoms of stiffness and swelling, we ask certain questions, and especially in young women, such as rashes. So if you have a rash, and it doesn't have to be the butterfly rash, there are other rashes associated with lupus. If the patient has what we call Raynaud's phenomenon, in other words, the fingers change color, they become pale and blue on exposure to cold. If the patient starts to lose hair or has chest pains all of those are symptoms that might indicate that we're dealing with more than arthritis, hence we might be dealing with lupus. And again, to make the point that the blood investigations are supplementary to the clinical examination. And we do the blood investigations really to confirm the diagnosis and also to stratify patients. And in lupus, it's really important to remember that not all lupus patients have the same degree of severity. So there are patients who have just skin and joint disease. And on the other extreme, we have patients who've got the more severe end of the problem, such as kidney inflammation or brain involvement, in which we need more aggressive treatment.
So let's talk about the symptoms and the signs that you touched on, and how sometimes it's difficult for patients to present, for instance, because these things don't necessarily happen at the same time. So what are the big flare-ups for lupus that we need to be aware of for patients to say, you know what, Prof once said that if I have A, B, and C, I should potentially go see someone so that I could potentially see if I've got lupus or not?
Okay, so the constitutional symptoms, and I think the patient highlighted that very nicely. This feeling of fatigue, right? Weight loss, okay? And possibly fever, together with the joint pains, together with the rash, right? Are features that would make us think of lupus. In some patients, they will notice that when they go out in the sun, they feel unwell, or they get, the skin becomes inflamed. That's what we call photosensitivity. And unfortunately, there are some patients where the kidney problem is the presenting problem, so they will develop high blood pressure and there will be protein in the urine. But that's the minority of patients. The majority of patients will present with the constitutional symptoms, a bit of joint pains, the skin rashes, loss of hair. And unfortunately, and I have to say this, that in our context in South Africa, often patients are labeled as having possible HIV. There's this misconception that lupus is the same as HIV. They can look similar, but the treatments are vastly different. And obviously today we have treatments for both of them. So, let's be clear about this. Lupus can sometimes look like HIV infection, but it's quite a different disorder, and the treatment is very different too.
In terms of treatment, I think we've spoken about medications that people can take should they be diagnosed, but are there any other lifestyle modifications and things such as that patients can do once they have been diagnosed with lupus or rheumatoid arthritis or any other autoimmune disease that make their life just that much better?
Yeah, so the common question we get asked is about diet, right? And actually, diet makes very little difference for these two conditions. There is no good evidence that diet will make any difference, any improvement. However, one of the lifestyle changes that needs to be changed is that of smoking. So we know smoking makes rheumatoid worse. We know that smoking in the context of lupus can make the rash worse, and that the medication, particularly the antimalarials, do not work as well in smokers as compared to non-smokers. So I think, giving up smoking for all other good reasons is important in patients with autoimmune rheumatic diseases. For the lupus patient, it's important that they stay out of direct sunlight. Okay, the UV light actually revs up the immune system, and it not only affects the skin, but it can also rev up the immunity and inflammation within internal organs. And we strongly suggest to patients with lupus to wear a sunscreen lotion, wear a hat when they go out. Okay, and that's often helpful. There are other measures that are specific to certain groups. For instance, the young lupus patient, oral contraceptives need to be taken with caution because they can cause a flare of the lupus. But yeah, weight loss is obviously, just keeping a balanced diet and a reasonable weight is enough. You don't have to take any kind of, you don't have to take a slimming diet or anything like that.
Are there any conditions that leave you susceptible to getting when you have lupus as well as RA or any autoimmune disease? Do you get other infections or diseases easier?
Yeah, so both those conditions, because there's dysregulation of the immune system, right? They predispose you to infections, and particularly chest infections. So in lupus patients and to an extent in rheumatoid patients also, we would strongly suggest that in the winter months to take the before the winter months to take the flu vaccine and probably the pneumococcal vaccine as well to prevent pneumococcal pneumonias. This is really important. When we see a sick lupus patient coming into hospital, we actively rule out infection, because we know that half the time, or 50% of the time, the patient who comes in sick to hospital has probably got an underlying infection together with a flare of the lupus.
All right, Prof, just before we head off, we have a quick question from Obile saying that I have a 15-year-old boy. Always all the joints are swollen, painful and stiff. Hands are now deformed. Shoulders and elbow joints recently, the knee joints also. This affects his daily activities as he's a soccer player and he's only given pain meds when he consults. What needs to be done here? I think this will encompass and sort of wrap up our discussion with respect to what's going on with this 15-year-old, Prof.
Yeah, I think this youngster needs to see a specialist as soon as possible. I think ideally to go to a rheumatologist. I'm not sure where where he resides, but after the show, if they, through you, if they want to contact me, I can guide them where to go. There are many good state services for the management of rheumatic diseases. And of course, in the private sector, we have many rheumatologists as well. But this youngster needs to see a rheumatologist as soon as possible, because what worries me is that he's already developed deformities. We should be acting rapidly, quickly on him. And remember, painkillers don't make any difference to the underlying inflammation. We need to treat him more aggressively.
Just one more point on just young patients. Do we see a lot of young patients presenting with these autoimmune disorders?
Well, again, it's relative. Obviously, it's not as common as, say, a pneumonia, for instance, right?
Yes.
But autoimmune diseases do occur in children, and we're fortunate now in this country that we have pediatric rheumatologists who specialize in taking care of children with rheumatic diseases. And what's the nice thing is, again, in children, because they, their bodies are much more plastic and they're growing, when you do treat them, they respond much quicker. But you need the expertise to recognize the problem and to manage appropriately. So, I would strongly urge people, if you do have children, we know of children or infants at the age of 3 or 4 developing arthritis, unfortunately. So, age is not a criterion to exclude people of having a rheumatic disease or an autoimmune disease. Unfortunately, it can occur at any age, but for the most part, it's not common in children. Yeah.
Thank you so much, Prof, for joining us this morning, and I think addressing the issues around autoimmune diseases. And I think it's important to note that, these are diseases that can happen across all age groups, as Prof has highlighted. But when you feel like something is wrong, go out and get the help that you need. There are many facilities in private and in state that can assist you so that you can get the help that you need and you're not getting to a point where you've got debilitation or you've got some sort of long-term effects that will come from you not having received treatment before. That was Professor Mohammed Tikli, Professor and, of course, a rheumatologist at the Chris Hani Baragwanath Academic Hospital. We're going for a quick ad break. When we come back, Dr. Marlon McKay joins us as we answer some more of your medical questions. Welcome back to Vital Signs. I'm Dr. Musam Tombene, and we're almost at the end of the show, but we won't leave without speaking to Dr. McKay as he answers some of the questions that you may have with respect to COVID-19 or any of the other conditions that you may have at home. So let's say good morning to him. Good day, Dr. McKay.
Good day, Doctor. Thanks for having me again.
Right, so let's jump into it. Last week, great news coming out of teenagers between the ages of 12 and 17 being able to go out and get their jab. How have you seen this in practice? Have you been getting a lot of inquiries from patients that come see you about this?
Right, yes, and interestingly so. Well, firstly, at 8 o'clock, exactly 8 o'clock last week, Wednesday, I registered my son. He went to school, and by 3 o'clock the afternoon, he was jabbed, and by the evening, I could already upload his digital certificate.
Sure.
So there's great enthusiasm. I find a lot of families have been calling in. I had a mum call in to say the one brother wants it, her son, the big one, and the younger one says he's not too keen. Spoke to both of them, let them understand the importance of it, and by Friday afternoon they had both been jabbed. So I think it's just there's a lot of hesitancy. It's definitely not an anti-vaccine sentiment. Hesitancy, and we just have to convert that hesitancy into vaccine readiness and then vaccine confidence, and we're seeing it. And what the data is showing is that, especially with Delta, kids got very sick. Initially, we were saying, don't worry, kids have mild illness, they're never going to land up in hospital. But we had quite a few kids who actually landed up in ICU. So the message is clear. Our children do need to be vaccinated in addition to the adults.
What are some of the big highlights or the big questions that the parents or the kids are potentially asking you with respect to getting the vaccine? What are their big concerns? What's the hesitancy?
The big thing is safety. What is in the vaccine? How do we know it's going to work? And how do we know that it's going to not cause harm to my child? And especially questions like fertility later on, men's health issues later on for boys, the issue around the myocarditis and the inflammation around the heart, which is a problem, and hence that we're having just the 1 dose of Pfizer, not the 2 dose for the under 18s. So it's just a lot of, and it's mostly based on social media and what they have heard, what is out there. But once you take them through it patiently and show them the data and the safety, parents do come around. Having said that, remember, we're also saying that the kids don't need consent, but it's nice to have the buy-in from families so that they can go together and do it together.
Is there a big problem in practice when you're seeing the kids potentially wanting to get vaccines, but the parents being the ones that are hesitant, having not gotten the vaccine themselves?
Yeah, I think I haven't seen much of that. But I think that the kids are also open, the kids are independent, they are also reading, and they can see the benefit that the vaccine has had. And also, kids want to get together. Kids are social beings. They're thinking of those parties, they're thinking of those gatherings, and they know the license to get there is the vaccine. So maybe their motives are not as pure as they should be, but there's lots of excitement around the vaccine, irrespective of parents' views.
All right, good to hear. So let's get into some questions that the viewers may have with regards to their health. Hello, everyone. I have COVID 6 weeks ago, and I'm still struggling with exhaustion, headaches, nausea, and brain fog. Every day feels so overwhelming. How do I sort this out? How do we get this done, Doc?
Yeah, so WHO has come out with a definition, and we're talking here about post-COVID sequelae, or what we call long COVID, the persistence of symptoms or new onset of symptoms after a recent COVID infection that is not explained by any other pathology. So this is classically long COVID. It is classically, in terms of the symptoms, fatigue is right up there, the brain fog is right up there, chest pain, cough. So number one, it's real. Number two, it does not mean that you are still sick with COVID, or does not mean that you are still infectious. You are no longer infectious, but it's as if COVID has left, the virus has left you with scars. The good news is that it will settle. The bad news is we just don't know. Another study came out yesterday, brain fog up to 8 months still persisting after a recent COVID infection. Okay, so just hang in there. It is going to get better. You may need 1 or 2 things from your GP just to help, but there is no quick fix. And just know that Israel, it's not part of. You're not still sick from COVID, it's just leftovers.
Let's revisit brain fog, and I think maybe some long COVID, other symptoms that we do have, where people really complain of just not being as sharp as they were in the past. How would you determine or define brain fog?
Yeah, so it's a lot of it is the ability to stay focused. It's the memory issues. So it's almost as if it's very similar to what you would look for in either adult ADHD or even in children. This easily distracted. They're not focused. People say you're just not present. You're here, but you're not present. It doesn't look like you know what you're doing. The lack of confidence in normal, you can't handle numbers and figures as sharp as you used to be. You're quite forgetful. You become unsure of yourself. And then it's just like your brain is, there's a real, as the word says, a fog, a heaviness over your brain. And sometimes we just have to use some of these stimulants just to kick things back into order. Otherwise your work suffers. You can't get back to normal. You forget how to cook, what must come in order. Simple things that you had no problem doing before COVID.
Okay, another question here from Happy Mahlang saying, my stomach is painful and under both ribs. Even now after eating, it's hurting a lot. I've been taking Myogel, but not getting any better. It is becoming worse. Any idea what it could be? Doc?
Yeah, so the classic clue there is after eating. So the moment you have some sort of stomach or foregut symptoms after you've eaten, it usually implies acid and usually acid reflux. So the product that you are using right now is more for symptomatic relief. So it just tends to relieve it, make it feel a bit better, but doesn't sort out the problem. And so you need a tablet that will suppress the acid production, what we call a proton pump inhibitor. There are some that are available over the counter in small quantities and low doses. So you can ask for some like lansoprazole that is available at the chemist. So you need something that will just inhibit or slow down the amount of acid. And of course, change your diet. Stay away from the spicy things, the strong foods. If you're smoking, please stop smoking. And that could calm things down a bit.
I think let's take a little step back and talk about vaccines once again. I think a lot of people have their reservations, especially after hearing stories where someone really complained about getting the jab and thereafter not being able to have a significant taste. The taste just wasn't there. Is this a side effect of getting the vaccine?
No, we haven't seen a lot of this stuff. Remember, the loss of taste and smell is usually associated with COVID itself and even with long COVID. So I'd be very hesitant to blame the vaccine directly. Maybe if it happened sort of immediately or within a few hours after the vaccine, possibly, but it's more related to COVID. Remember, other things like sinus, postnasal drip, acid reflux, all those things could also interfere with your taste and smell. And there's a lot of that going around right now.
Let's talk about vaccine side effects. I think it's a big thing that a lot of people that are vaccine hesitant like bringing up that, but what about the side effects? So what are the recognized side effects that we know about that you'd get when you've gotten the vaccine? And what are the myths or the lies that we keep hearing about people saying that they've gotten A, B, C, D after they got the vaccine?
Good. So the common side effects, just as a general statement, number one, side effects happen with all medications. Side effects are usually mild and are of short duration. The most common one, sore arm, which is usual after a jab like that. It's an intramuscular injection. And then within hours or a day or two, you can get the fatigue, chills, fever, body aches and pains, almost as if you have a flu-like illness. And then that settles. Usually just some rest and paracetamol settles it. But you can also get more serious but less common side effects. Things like everyone's talking about the issues with clots, issues with inflammation around the heart. These are extremely rare. And if one has something like that, obviously you need to report it. There's a portal that you can, or visit a doctor. But the common side effects are common, as we say, mild and of short duration. They do not carry on for weeks and months. And remember, the vaccine, it cannot give you COVID, cannot make you test positive, does not give you infertility, will not change your DNA, does not contain a chip or magnetic strip. All it does, it stimulates your immune system, make antibodies so that when you are exposed to COVID, it will cause, if you are going to get COVID, a mild infection, no hospitalization, and certainly not dying from COVID.
All right, a question here from Rajesh in KZN. Good day, Rajesh.
Hi, good morning. How are you?
We're well on our side. You have a question for Dr. McKay?
Yes, I do actually have a question. Okay, my question is, how is it possible for the government to give consent to children 12 years and older to get these vaccines? Because if you actually think about it, it's like telling the parents, you can take candy from strangers and not say anything. Logically, that's what you're telling the public. That's what the government is telling the public. You get what I'm saying?
I hear your question, Rajesh. Yes.
I mean, do you understand what I'm saying?
We get you. Dr. McKay. Yeah, we get you, Rajesh. You'll get your question answered now. Dr. McKay, the issue of children under 12s or over 12s up to 17 being able to, they themselves, walk into a facility without parental consent. Rajesh has a question about it. Why are we allowing this to happen is his question.
Well, this is not new. This is in the Constitution. The Children's Act, I think it's Act 38 or something, that already allows a child, anyone over the age of 12, provided that they are of sufficient mental maturity, that they can make a decision to fall pregnant, to terminate pregnancy, to seek medical assistance without the consent or of their parents. So this just automatically falls under that Children's Act. It's not something new. It's not something new that government suddenly decided, okay, now children can do this. It forms part of the of decisions that children can make without parental consent.
Mm-hmm. All right, another question before we wrap things up. Molweni Bethuna, is there anything I could use? So basically looking for help here with respect to a non-stop cough and chest symptoms that come post-COVID, so long COVID, and how we can handle the symptoms that come with it.
Yeah, so when you have something that's not going away, especially with the cough or chest pain, you have to visit the doctor just to make sure it's not something new. Make sure it's not something like asthma. Make sure it's not something like TB. I've had a patient post-COVID who presented with TB with the cough that didn't want to go away. So always exclude any other common pathologies that may present themselves as if it was after COVID.
Yes.
Once you've done that, yes, then there are a lot of over-the-counter remedies that one. Try and stay away from the normal cough mixtures. Find the cause of it and treat the cause, and usually they settle.
Very important. Find the cause and treat the cause. Thank you so much, Dr. Marla McKay, for joining us this morning as we discussed all things COVID and, of course, any medical conditions that you want to have a chat about. Important thing, though, that was noted is that children being able to go out and get the vaccine without parental consent is not a new thing. It is a right that is enshrined within the Constitution, and they're allowed to. What we actually need and want is the go-ahead and the big thumbs up from parents that want their children vaccinated so they can go out and get their one jab, as well as a nation that has adults and children that is vaccinated. That's how we wrap up the show today. Thank you so much for joining us. I'm Dr. Musam Tomene. We'll see you again next time on Vital Signs.